Hello everyone. Today we are here to discuss a case of poorly controlled diabetes with hypoglycemia risk. I am Dr. Vishnu Vasudevan. I am consultant endocrinologist in Kerala. So we'll be discussing about a 50-year-old gentleman who has diabetes for the past 2 years and who has come to us with frequent hypoglycemia events in the past 2 months. The patient is on metformin 1000 milligrams twice daily and a sulfonylurea, that is glimepiride, 2 milligram twice daily. His laboratory parameters showed HbA1c of 8.2%. His estimated glomerular filtration rate was 88 ml per minute per 1.73 meter square. His LDL cholesterol was 90 milligram per dl. His HDL cholesterol was 36 milligram per dl. His triglyceride levels were 126 milligram per dl. His AST levels were 33 units per liter. His serum creatinine is 1.1 milligram per dl. So now, looking at his physical examination, he has a body mass index of 31 kilogram per meter square. His blood pressure is 120 by 70 millimeters of mercury, and his heart rate is 78 beats per minute. So overall, looking at the case, we can find that it's a middle-aged gentleman who has a relatively short duration of diabetes and who has come with frequent hypoglycemia events because he is on a good dose of sulfonylurea glimepiride. Even after taking the two medications, that is glimepiride and metformin, his HbA1c is not under control, that is, it is 8.2%. He has a relatively good renal function and he is into the obese category, that is, his BMI is 31 kilogram per meter square. Now, how do we optimize the glycemic control in this patient? We know that cardiorenal protection is very important, and that is a primary treatment consideration in our patient. His A1C goal for many non-pregnant adults is up to less than 7% and go up to less than 6.5% depending upon the provider's judgment and depending upon the patient's preference. Especially, it might be acceptable if this can be achieved safely without any significant hypoglycemia or any other adverse effects of treatment. Now, we know that in 21st century, type 2 diabetes has reached epidemic proportions globally. Indians have a tendency for earlier onset of type 2 diabetes, leading to an accelerated risk of developing complications, making it more essential to address this pathology early in the disease course itself with all the available novel therapies which have minimum risk of adverse events. Now, strict glycemic control is very important. It's critically important in patients with type 2 diabetes. We know that sulfonylureas has been with us for a long time. They play a pivotal role in glycemic control. As a direct extension of their mechanism of action, there is a risk of hypoglycemia because it is not glucose dependent action. And this risk may be further increased in patients with renal impairment, especially this renal impairment being a common comorbidity associated with type 2 diabetes. Hypoglycemia is definitely a major concern for users of sulfonylureas. Now, the magnitude and severity of sulfonylurea-induced hypoglycemia ranges widely across studies, but in our clinical practice, we have found that most of the patients who come with hypoglycemia in the type 2 diabetic group, the most likely culprit is sulfonylurea if the patient is taking oral antidiabetic agents. Now, let's discuss the strong rationale for combining DPP-4 inhibitors and the CV protective class, that is SGLT2 inhibitors in people with type 2 diabetes. We know that these two drugs exert different and complementary glucose lowering effects. And furthermore, the increase of glucagon levels, which are induced by SGLT2 inhibitor, may be blunted by the co-administration of DPP-4 inhibitor. So this is a very interesting scenario where one sort of adverse event or the problematic event of SGLT2 inhibitor is directly counteracted by the other agent which we are using, that is the DPP-4 inhibitor. Now, clinical evidence also shows that SGLT2 inhibitor and DPP-4 inhibitor combination is an effective option for the management of type 2 diabetes and provides HbA1c reduction of 1.1 to 1.5%. That's a significant amount. And that much of HbA1c reduction is unlikely to be achieved by a single agent. There is another most important benefit, that is weight reduction. of approximately 2 kilograms when SGLT2 inhibitor combination is being added to metformin. Now, this is the primary place in its therapy where a patient, such as our patient who is obese, comes with type 2 diabetes, and we are preferring agents which will at least not increase the weight and try to reduce the weight. Now, American Diabetes Association also recommends initial combination therapy in patients who have an HbA1c level more than 1.5 to 2% above the target. This being the absolute effectiveness of most oral medications, which rarely exceeds 1%. So individually speaking, all the hypoglycemic agents or anti-diabetic agents can achieve a HbA1c reduction of only up to 1%. Always a combination agent is needed when HbA1c levels are more than 2% above the target. Now, our unique combination, which we are discussing today, that is the SGLT2 inhibitor and DPP4 inhibitor, they lend themselves to early treatment intensification because of good tolerability. There is a low risk of hypoglycemia, and there is a chance of possible weight loss also with a minimal treatment burden. We know that SGLT2 inhibitors give a good weight loss benefit, especially if the patients are obese. Now, clinical experience with type DP4 inhibitor and SGLT2 inhibitor combination also show that they have a good safety profile and a low risk of adverse events like hypoglycemia and weight gain when it is specifically added to metformin, which is a particularly important finding for clinicians. There is another important aspect, that is when we are initiating SGLT2 inhibitors, we are always worried about the genital infections which are commonly seen, or in many of the patients we see genital infections with SGLT2 inhibitors. There has also been reports that once we add DPP4 inhibitor, this chance of genital infections are reduced. This might be because of a better glucose control, but there are some other possible mechanisms also which have been reported, and they much remain to be investigated. So thank you all for the patience.